Here now to expand on some of the breakthrough studies with immunotherapy in lung cancer is Dr. David Spigel, who's the Chief Scientific Officer and Lung Cancer Program Director at Sarah Cannon Research Institute. Hi, Dr. Spiegel. Thank you so much for being here today.
Hey, Gina. Thanks for having me.
Oh, sure. Of course. So let's first touch upon the phase 3 Empower 110 trial.
Sure.
So this is looking at single agent atezolizumab versus chemo in the frontline setting for wild type non-small cell lung cancer with some other certain disease characteristics in there. So you could touch upon that trial?
Yeah, I think over the last 4 or 5 years, as immunotherapy has found its way into non-small cell lung cancer treatment, the goal is, can you get it into earlier lines of therapy? We know from Martin Reck's pivotal Keynote 024 study that pembrolizumab found its way into first-line treatment in high PD-1 expressing patients. At this meeting, we've heard about Checkmate 227, which we may talk about here in a moment. And then another big study in the first-line space, as you say, was this Empower 110 study. So really simple design. Could you take a PD-L1 inhibitor, in this case atezolizumab, and take on platinum doublet chemotherapy in newly diagnosed patients? A couple of caveats about this study. It was a randomized phase 3 with an OS endpoint, but you had to have PD-L1 expression, as you say, to get on this, but the assay was a little different than the Merck studies. So this was the SP142 assay, which measures PD-L1 expression by what's called TC, or tumor cell expression, or IC, immune infiltrating expression. And to get on the study, you could have any expression as long as there were some, so 1+ through 3+. The endpoints, it's worth taking a moment to understand this. So the endpoints were designed to be looked at in a hierarchical design. So you start with the 3+ and then go to the 2 3s, then the 1 2 3s. And you have to hit all of those to then look at the secondary endpoint of PFS. So I'll just jump into it. About 540 patients were randomized. About 35% roughly had the 3+ group. That's about 100 in each arm. And in that group, atezolizumab was superior to platinum doublet chemotherapy, regardless of histology, so squamous or non-squamous. The overall survival was in favor of atezolizumab. The hazard ratio showed about a 41% reduction in the risk of death if you're on atezo. So pretty substantial findings. The study met its endpoint. When you look at the 2 3+ survival advantage, it was in favor of atezo, but the p-value was 0.04. And 0.0416, I apologize.
Okay.
Because of the design, you had to hit 0.04, so it just missed it statistically. And therefore, the 1 2 3s, which also show a trend favoring atezo, technically is not positive either. When you go to PFS, it's kind of the same story. The PFS looks substantially in favor, about almost a 40% reduction in progression or death with atezo, but because you didn't hit the 3 strata, you can't say that's statistically positive. Response rate, duration of response appear to be in favor of atezo as well. The safety profile looks very good. And so what do I think this means? I think this means we have a new standard of care in the first-line setting in addition to pembrolizumab, and as we'll talk about in a moment, nivolumab, ipilimumab, hopefully in the 3+. And there's ongoing work to, this was an interim analysis to see if another group hits, so there's a chance 2 and 3s or 1 2 and 3s can hit. And there's ongoing biomarker work, so because 22C3 is an assay that's probably more prevalent than the SP142, there are going to be analyses presented here soon showing how the data look when you look at it using a 22C3 assay or an SP263 assay, and also some blood TMB data are going to come out. So more to come, but this is, I think, a big step because it brings another therapy into the first-line setting.
Definitely. It's a study with a lot of layers in it, too.
A lot of layers.
Yeah.
Gosh, every study now seems to have multiple layers and endpoints, so that's just the way it is.
Yes, speaking of which, let's move into the Checkmate 227 trial. Again, another trial with a lot of pieces to it.
Yeah, it's funny because I live in lung cancer, as do a lot of my colleagues, and you got to keep up with it. So I'll try to make this simple. So Checkmate 227 was basically the attempt to see how BMS can get into the first line space. You may remember a pivotal study of Nivo versus platinum doublet chemotherapy in the first line called the Checkmate 026 study was negative. and so that didn't mirror what we saw in Keynote-024 with pembrolizumab. So this study's a little different. It was nivolumab and ipilimumab, a regimen which already has a U.S. label in 3 cancers, so in advanced renal, advanced melanoma, and advanced MS-high colorectal. So we know it's an active regimen. We've known it's active in small cell and non-small cell, but this was the pivotal registration trial to get it approved. Complicated design. Nivo-Ipi, chemo-Nivo, or chemo. There was no Nivo arm alone because of the 026 data. Everything was looked at. PD-L1 expression, histology, squamous, non-squamous, and TMB. And I think, Gina, what you're alluding to is a pivotal New England publication from Matt Hellman, and many presentations have focused on TMB. That is to say that Nivo-Ipi has looked great as a regimen, especially in the high TMB population, and I think we all thought that's the path to registration. And at this meeting at ESMO 2019, we got a press release ahead of time, but we saw the data that Nivo-Ipi was better than platinum chemotherapy. However, not because of TMB. It actually looks okay with the TMB group, but in the PD-L1 1+ or higher. So here we are now back to PD-L1. And what I think this means is that Nivo-Ipi will become another first-line regimen available in our expressors. And so in my view, we have 3 regimens kind of showing the same thing, that if you have expression, in the case of Atezo, high expression, and you can make the argument in the case of Pembro, the highest expressors kind of carry the weight, even though it has an approval in the 1% or higher. We have a 3rd regimen available. A little bit more safety concern with that, with Nivo-Ipi, and I think if you haven't used it, that'll be something you have to get used to. But I think it's good for patients to have different regimens, and hopefully this provides new platforms to build upon.
Good. You definitely simplified it.
Yeah, right.
Yeah. So let's move on into small cell lung cancer. So
yeah, sure.
There's a presentation of updated OS analysis of the Empower 133 trial with atezolizumab and some chemotherapy.
Yeah.
So what are your thoughts on these data?
So, small cell has been obviously something I'm very interested in. We see a lot in our region in the southeast of the United States. Chemotherapy is good, it's just not great. It doesn't have lasting effects in everybody. Everybody recurs. And our options beyond that are not great. And so what we learned with Empower 133, and actually I may, with your permission, talk about the Caspian study.
Yep.
We have 2 studies that show if you give platinum etoposide with a checkpoint inhibitor, in the case of 133, the PD-L1 inhibitor atezolizumab, in the case of the Caspian study, the PD-L1 inhibitor durvalumab. Both studies, in my mind, show kind of the same thing, that there's clearly a survival advantage if you get the triplet as opposed to the standard of care for the last 20 to 30 years of platinum etoposide. And that's a big deal. We're a little spoiled on the non-small cell side because we've seen such great curves in survival and PFS and response rates. I think a lot of us, or all of us, were hoping that the results would be even more substantial than they have been. And that's not to say they're not good, and they're huge steps forward for our patients. I think we want more. We want to learn more about who benefits the most. Can you select out those patients? So far, PD-L1 and TMB don't seem to help at all. Does everybody need maintenance? Does everybody need to get that triplet? What about radiation to the chest? What about PCI? There's still a lot of questions. And once you relapse, are you done with IO? Kind of like in non-small cell, do you have a chance to get it again in some other way or some combination? These are the things we'll discover in the next probably 2 to 3 years or 5 years.
All right, great, thank you. So the BE-FIRST trial, that's a study looking at blood-based TMB as a predictive biomarker for frontline atezolizumab. So just kind of looking at trials like this, can you kind of speak to the importance of looking for this ongoing search for biomarkers, and especially biomarkers that are predictive of response to immunotherapy?
Yeah, I think what is exciting about this kind of work is the idea that we're going to start using the blood to make decisions. I mean, that sounds kind of silly because we've always done that in medicine with blood work. But we're talking about more sophisticated blood tests now, genomic testing, and you're referring to something that's even more sophisticated, tumor mutation burden. But in the blood now, in the standard of care setting, you can measure things like EGFR. You can measure markers to help you guide therapy. In our network alone, we're doing about 700 comprehensive molecular tests a month, and half of those are blood-based, and we're seeing that grow exponentially. You know, that has me worried on the research side in that, is that enough? You know, hopefully we're getting tissue too, but I do believe that in the future, blood will probably be the way we're doing everything. And so BE-FIRST and a companion study called BE-FAST are designed to use blood up front to make decisions. Can, for example, a TMB value help you make a decision, in this case, who gets atezolizumab or platinum doublet chemotherapy? Can you also find RET? Can you find EGFR and implement decisions in care because based on that blood test that help the patient do the best? Blood tends to be faster in general. We get it back in 5 to 10 days. Tissue testing right now is taking about another week or two beyond that. And so this offers a real opportunity to make earlier decisions in care with less invasiveness. So I'm excited about where this can go and hope we're going to see more data, more studies like this.
That's great. Thank you so much.
Yeah, thanks.
What there's been a lot of great lung cancer data being presented here at ESMO. Is there any other studies focused on immunotherapy and lung cancer that you'd like to share light on?
Well, there's a lot. You know, I think the FLORA data, not immune-based topic, but certainly osimertinib's survival advantage over erlotinib and gefitinib is pretty nice to see. I actually was going to jump around a little bit and tell you that I'm pretty excited about the work in DNA repair with the PARP inhibitors in ovarian cancer and also in prostate cancer. I think the reason I'm excited about that is I think those are untapped places for lung cancer research. I mean, folks have studied these kind of drugs in combinations in small cell, but not in selected ways. You know, we saw this past year BRCA in pancreatic cancer can be important in making treatment decisions. And the role of DNA repair targeting and immunotherapy, I think, is the next kind of is a frontier that everyone is kind of excited about. What is the interplay? Are there ways to select patients based on blood testing or tissue testing or other assays? I think that's going to be a next exciting area for all of us, but especially in lung cancer. I think it's kind of an area that's ripe for some good research.
Thank you so much, Dr. Spigel.
Great.
This was fantastic. Really appreciate you coming by today.
Okay, thanks, Gina. Appreciate it.